this monitor. The supplies for this monitor on 2 South are on the non-stock cart, closer to the odd side of the hall, in the very top in a black container. And you've got 2 different things. You've got a moisture trap and the cannula. And this cannula is split. This, we don't use that, so that's okay. But this cannula is split, the tubing is, where you can open that up. One side goes to the flow meter, and then the other side's going to go to your CO2 monitor. So they can have oxygen and monitor the CO2. This cannula has the little holes at the bottom where it measures the exhaled CO2. And this plugs right in here and screws in. Have you got to use this yet, Tish?
Does it work well for you?
They alarm a lot.
Okay.
Was that the problem? You guys had just
Oh my
alarm.
We have not had a patient, to be honest with you, that we felt like they just really worked.
Okay.
I mean, we put them on very healthy people, that they should be reading without any problem at all. And, I mean, the numbers are everywhere. And then you put it on somebody that you really think you need to have it on, and, I mean, we don't use them because that's how unreliable we feel they are.
So we'll have to talk to the rep and see how he can,
I'm very
help
curious.
us with that.
I don't know if it's the way we're putting in the moisture trap, or if the cannula is just not sitting in the nose right to where it can, I don't know. It doesn't even give a waveform.
Yeah. I mean, it's not just the
even when you breathe through your nose.
I mean, like if you put it on you standing up there, they work fine. But if you have it on a patient that's laying down,
or if they breathe partway through their mouth and partway through their nose, or I don't know if that's possible, but if they're partially mouth breathers, then that's the problem.
we've even put it down by their mouth.
And it still didn't. That's too bad.
And yeah, it's.
We were excited.
ER hasn't had any problem with this, so, but I know that's not an option downstairs.
It is in surgery, but it's not in recovery. Not for our non-nurses.
This gives you respiratory rate, it gives you the entitled CO2, and it has alarms. But do you want me to go into that?
Why don't you talk a little bit about the Bipap? Do you want to do a
I'll
little
go
on
into
that?
Sure. The Vision, and we are in the process of purchasing a new Vision, and it's just a sleeker, newer model. This thing's going to look huge after we get the new one. You can do BiPAP or CPAP on this. CPAP is, you can't exhale all the way. If I could put a monitor right here and I could monitor my breathing, the pressures. When I go to exhale, it's going to leave a little bit of pressure in my lungs, and it keeps the airways open a little bit more, and it gives more room for gas exchange to take place. So CPAP's more for oxygenation.
So it's more of a forced thing?
It's a continuous positive airway pressure, so it's a continuous pressure that you could set of how high you need that to be, and they're exhaling against that pressure, and it's a little bit of air that's left in it for oxygenation. BiPAP, the number that we set, bi means 2, so the BiPAP that we set, the top pressure, is for ventilation. So it's non-invasive ventilation, so we're really ventilating someone without a tube. And we're giving them baby breaths, but we can see on here about what the breaths are. Okay, what has really helped 100% with nursing on 2 South is that we have a bedside report form that we go over when we hand the patient off to the nurse, and then that nurse, when she goes to the next shift, she actually uses that and takes that nurse into the bedside and goes through each step of this and checks off, yes, I know where this is, and this is. Because you might be a nurse on 2 South and you might not have had a BiPAP patient for 6 months. And all of a sudden you walk in, it's like, okay, now I need to remember how to do that. So I will, if you want to go through this with me, I'll just go through each thing. The on and off switch is in the back, and this is how I in-service the nurses. It's way over here in the back.
Is there more?
Tish already knows this. Okay, the machine's going to do a self-test when we turn it on. Don't look at the screen. The first time that we turn it on, you guys, the nurses don't set up the BiPAP, so you wouldn't be responsible for this. But the first time that we set it up, we're going to do a test to test the exhalation port, because this little hole right here is where they exhale, so you wouldn't want to cover that up or tape it up. Or so if you feel air with the mask, and that's probably where that's coming from. So the first thing I'll do is I'm just going to follow the instructions on the screen. I'm going to test exhalation port, and it tells me what to do. And this is, I'm going to occlude the end and start test. And it's just testing to make sure this is open, so the patient, the air is just not forced in there. And it says that's okay. Press monitoring to exit. So I'm going to push monitoring, of course. The screen has shows up 4 different screens. We have monitoring, parameters, mode, CPAP or BiPAP, kind of like take it or leave it, and we can set alarms. So now what do we do on our sheet? What?
Select the parameters.
Select the parameters, okay. So we're going to go over to parameters. This is how you set how big of a breath you want them to take, your inspiratory, expiratory, rate, and FiO2. So we would go over that with each nurse. These are what the settings are. The inspiratory, it's not a touch screen. It looks like it should be. And of course alarms. Inspiratory pressure, if you could monitor the air right here at my mouth, I want that to give me a boost of 14. If you could see a little 14 centimeters of water pressure, if you could see a little gauge here. I just want it to give me a little boost of 14. And expiratory pressure at 6. I'm going to leave a little bit of CPAP in there. And so when we're looking at our blood gases and making changes, one of the things for CO2 would be if the CO2 is high, we would increase this, or we could increase the rate. A rate that I've got it set at 8 breaths a minute, so the machine's going to give 8 of these little breaths using that much pressure a minute, but the patient can breathe in between that as much or as little as they want to. At the very bottom down here, you can see tidal volume, this is the patient, minute volume, which is the tidal volume times the respiratory rate, peak inspiratory pressure, which is that thing we're setting. Then it divides them, it shows how much of a leak we have. When we put the mask on, it's not a closed system like the ventilator is. You know, if you lose air through a bad connection in the tubing, or your cuffs low, then you're not giving that breath. You have to be spontaneously breathing, of course, and there's so many variables in how tight the mask fits, if the patient's coughing, talking, trying to get comfortable, all those things cause alarms. Okay, so we've set inspiratory, expiratory, the rate, the alarms, of course. It gives us just a little picture here of a gauge to show what inspiratory pressure that we're setting. And the same thing for flow and volume. Monitoring, this is what we've got set. So monitoring is what's the patient actually doing. You know, we want this much pressure to go in, inspiratory and expiratory, and the rate, we've got that set. But is the patient breathing 25? Just another measure to show if your patient's comfortable or not. And of course the O2. Alarms, and I've got the sheet where you just go down the line. High pressure alarm. For some reason, this pressure has went to 22. I've got it set at 18, but for some reason it's went to 80 for 22. I've got it set at 18, but for some reason it's went to 22. The patient coughed, you know. Instead of just have that pressure keep going and going until the patient's lungs are damaged, it shuts off right then. And terminates. If it's trying to give a breath, it'll stop the breath. And low pressure is more of a disconnect. Low pressure delay, it's going to wait 30 seconds because there's so many variables in the mask fit and the patient's awake and talking. So there you have a 30-second delay in that, and it's got a 40-second delay in apnea, which seems like a long time, and we wouldn't put that on a ventilator, but you get so many false alarms with this. So that's why we do that. It's got also a low minute volume and high respiratory rate, which is a patient, you know, the patient's breathing fast, or the monitoring screen. I've only got the rate set at 8, but the patient's breathing 40 times a minute. So why? You know, you assess the patient just like you would any other patient. Is it pain? Is it they need something? Anxiety? Has their condition worsened? You know, are they having bronchospasm? Do they have secretions that they can't control? So you assess your patient with this machine and any other machine the same way you do any of your nursing assessments. And then mode, you won't have to mess with that, and that's just CPAP or BiPAP. When you give a breathing treatment, depending on your patient, and by the time we leave or on the weekend, you will know on 2 South if you want to give the aerosol treatment and take the mask off, you'll know if it's someone I can take this off for 10 minutes and put the mask back on. It's not a ventilator, or is it someone that's more critical and it would be safer? You have to use your judgment to put the aerosol in, and we're going to put it in right here. And I didn't take this apart, but that's one of the things that we do on the checkoff. This is how I gave the aerosol. This is where the aerosol, you know, the neb is. And we're just going to put that T-piece right here with the nebulizer, and we're going to just run that to oxygen. Before we do that, we're going to go into alarms, and we are going to go into learn-based flow. So if you're teeing the nebulizer in, there's all that extra flow is going in. So you just push learn-based flow, set your nebulizer up when the treatment's done, then you push it again when you take the nebulizer out. So the machine knows what it's looking for. The alarm is a silence and a reset. When you come back into the room, you can look at the top of the screen and see what alarms have went on. I've had a low minute volume, so low I've had some kind of disconnect, and apnea. So, and it's the same with the ventilators. If it's a high alarm, if it's a high pressure, there's, for some reason that air can't meet its target. So coughing, bronchospasm, biting on the tube, or if it's low, it's some kind of disconnect. You can actually, I won't say this on video, but you can